All right, so I'm recording, and this is video 3 of the gold standards for COPD exacerbation. My name is Lexi Graham, and in this video, we're going to be talking about maintenance therapy. So, initial pharmacological treatment. Most COPD patients will be prescribed some type of pharmacological treatment. To assess the patient for what their medication needs may be, the patient's treatment plan should be based on their individualized symptoms, exacerbation risk, and their blood eosinophil count. This assessment is called the ABE scheme. This provides clinical guidance to prescribing their pharmacological treatment. And this is kind of a little picture of what that would look like, but we're about to get in more depth into it. So the ABE scheme. The ABE scheme is divided into 3 categories that are separated based on the severity of the individual's disease process. Group A requires the least amount of pharmacological intervention due to the reduced severity of their symptoms. Group B requires additional pharmacological treatment in addition to Group A, based on an increase in the severity of their symptoms. Required additional pharmacological treatment in addition to Groups A and B. This group is for patients with very severe symptoms. So A, B, and E, which is ABE scheme. A is kind of bad, B is pretty bad, and E is the worst. And this is a picture of what the ABE scheme for the gold standards, what that looks like. And then we'll go on to the next one. So Group A, the treatment plan consists of bronchodilator treatments based on the effect it has on breathlessness. A short and long-acting bronchodilator can be used. Long-acting bronchodilators are preferred, but is more expensive and less available. Short-acting bronchodilators are preferred when the patient presents with very occasional breathlessness. So if you have occasional breathlessness, you're going to be using a short-acting bronchodilator. Group B, the treatment plan will consist of a long-acting beta or a long-acting broncho beta agonist, and then a long-acting muscarinic agent. Studies have shown that this combination is the highest ranked treatment group to reduce COPD exacerbations. Group E. So Group E treatment plan consists of a long-acting beta agonist and a long-acting muscarinic agent with the possible indication for an inhaled corticosteroid. The LABA, LAMA, and inhaled corticosteroid combination has been shown to be the better be better than just a LABA or ICS. And then a LABA and ICS in COPD patients is not encouraged. Maintenance therapy. So what type of drugs are they going to be using? So like we were talking about on the last slide, SABA is short-acting bronchodilator. LABA is a long-acting bronchodilator, and then LAMA is a long-acting muscarinic antagonist. Inhaled corticosteroids and then combo drugs are all things that would be maintenance therapy for COPDers. And then here's a few pictures that I have of them, and then some of their dosing or their dosages, but we're also going to talk about those as well. So first we're going to talk about bronchodilators. So bronchodilators can increase the FEV1. They help dilate the airways to COPD patients and help them breathe more effectively. They can reduce hyperinflation at rest and during physical activity and can help improve exercise performance. So a SABA and a LABA combo can be paired together address the acute need for quick relief, which would be the SABA, and can maintain the long-term need for control of bronchospasms, which would be the LABA. SABAs are a quick relief medication that are indicated for treatment of acute episodes of bronchospasm and help relieve feeling of breathlessness. And then LABAs are the long-term maintenance drugs that are indicated for long-term control of bronchospasms with COPD. This is just a more simplified version of what I just said in that last one. So SABA is acute, LABA is long. So we're going to talk about the short-acting beta agonists. So these are the delivery methods and duration, and a few pictures of them. So salbutamol, it can be delivered through an MDI, dry powder inhaler, or nebulizer, pill, syrup, or even injection. And the duration is 4 to 6 hours. Levolbuterol can be delivered through an MDR nebulizer, and this is 6 to 8 hours. Um, um, and then formoterol can be used in an MDI, nebulizer, pill, or syrup, and the duration is 4 to 6 hours. And then terbutaline can be a DPI, pill, or injection, and this is 4 to 6 hours. Again, short acting. Long acting beta agonists. So arformoterol, this can be a nebulizer solution, and it is up to 12 hours. Formoterol is DPI nebulizer and is up to 12 hours. Indacaterol is a DPI and is up to 24 hours. Olodaterol is a soft mist inhaler and is up to 12 hours. And salmeterol is an MDI or a DPI and is up to 12 hours. So the long-acting muscarinic antagonist, these delivery methods, so we'll have N-selenium bromine, which is a DPI. The duration is up to 12 hours. The glycopyrronium bromide, DPI, it can be a DPI or oral solution, and is 12 to 24 hours. Tiotropium is a DPI, soft mist, or MDI, and is up to 24. And then umesolidium is a DPI and is up to 24 hours. This type of drug is another approach to control bronchospasms. LAMAs block the bronchoconstriction caused by acetylcholine. These block the neurotransmitter, preventing it from causing the muscles around the airway to constrict, and this reduces symptoms in those with COPD. So essentially, it's blocking those acetylcholine neurotransmitters and preventing them to swell, thus causing an exacerbation. So inhaled corticosteroids, these are anti-inflammatory drugs that affect bronchodilation directly and indirectly. COPD patients that also have asthma are required to take this. So anyone who has asthma should have a maintenance inhaled corticosteroid. Some side effects of this would be hoarseness, osteoporosis, vision problems, or oral thrush. Oral thrush is the one we see the most. So whenever you're giving these to patients, you want to make sure that they're rinsing their mouth out after they have used this inhaler. And you'll have fluticasone, budesonide, which is most common, and then beclomethasone, flusones. These are the most common ones that I have seen. And then for combination drugs, so you have a LABA and inhaled corticosteroid, so long-acting with a steroid. It's formoterol and beclomethasone. That is a DPI or an MDI, and this is up to 12 hours. You have formoterol budesonide. This is a DPI or an MDI and is up to 12 hours. Formoterol and mometasone is an MDI, which is up to 12 hours again. Salmeterol and fluticasone propionate is an MDI or DPI up to 12 hours. And then vilanterol and fluticasone furoate is a DPI and it is up to 12 hours. And these are just a few that people might see. Advil, Dulera, Symbicort. These are all very popular ones. This is the most common one that you'll see COPDers have. It's the 3-in-1, so Trelegy 3. So you have 3 different type of drugs in these. Trelegy Ellipta is just the most common one that I've seen. So one of these will be fluticasone, umesolidium, and bilateral. That is the Trelegy. It's a DPI and it lasts up to 24 hours. You may also have beclomethasone, formoterol, and glycopyrronium, which is an MDR DPI, and this lasts up to 12 hours. And then you also have budesonide, formoterol, and glycopyrrolate, and that is an MDI, and that lasts up to 12 hours. So this one has all 3 of those, and is very helpful to the COPD population. Some factors to consider when initiating ICS treatment. So you're gonna want to get the history of hospitalizations or exacerbations of the COPD patient. And then if it is greater or equal to 2 moderate exacerbations of COPD per year, you're going to want to know if their eosinophil count is greater or equal to 300 cells. And then a history, or if they have a history of asthma. So if they have history of asthma, you're going to want to know that too. You're going to want to know if you're going to have to know if they have how many exacerbations they had and how often they had it in 1 year, what their eosinophil count is, and then what their if they have asthma. So these are just a few things that you need to get. And then that is all we have for this video. And thank you for watching.